Hey, everybody out there in cyber world, we're here for our second episode of Raves and Occasional Rants, and I got the A-team with me again today. We got Dr. Miguel Ortiz, we got Dr. Richard Young, man, friend of mine since we were probably born in the same crib almost the same day, and Vita Maharishi. I always get that wrong. Why am I so problematic with that? I like two-syllable words, everybody, so Maha. We'll keep it at that. Okay, so she's here again. She's like one of the brightest people I've ever met in my life, and have done a lot of research with her over the years, and so she's going to share a literature review, and that's kind of where we're going to start. So let me introduce everybody out there and say hello. Richard, say hello to everybody. Hey, can you hear? Hey, great. Good to see you, buddy. Dr. Miguel Ortiz, give us a hi, hello.
How are you doing, guys? I'm here in Boston. It's going to be awesome today. What are we talking about today? Like materials, stuff? Can I rant? Can I rant at the end?
Well, we'll rant for a second, and then we'll get into, we got all kinds of fun things. So the layout is kind of the same as before. We're going to start with the literature review today because people asked us to kind of do that. And we started with zirconia last time, and we want to talk a little bit about the material of zirconia. Today we're going to talk about some bonding issues and some of the research out there, and we're going to share some of the stuff we've did. And then we'll get into some fun things that we think are good in dentistry, some things that we think are maybe problematic, and then we'll finish up with some questions and answers. And then, like last time, we're interviewing this time is Celine Heighton from England, somewhere near London. I can't remember exactly what city. She is just an absolute fabulous a young dentist. And God, everybody that's under 50 is young to me, okay? And she does some amazing work with adhesion, composites, rubber dams. So we interviewing her from England tonight. So let's start first with Dr. Maharishi, and let's get into our literature review. So Anvita, why don't you share the screen, and we'll get into that, and then we'll talk about it when you get done.
All right. Thank you so much, Dr. McLaren. As always, I'll be doing the literature review segment for the Dental Raves and Rants podcast. As you would know from the first episode, we discussed surface treatment of different zirconia and some in vitro research we have done so far and some published literature out there. And also we raved and ranted. Today, we would be discussing more about zirconia bonding, and then what's the current literature look like and what's the research gap that we need to still work upon. So let me move on to my next slide here. So question of the decade actually is to resin bond or to cement a restoration, isn't that so? And then there are different bonding protocols and surface treatments based on the material used. For example, the silica-based glass ceramics are surface treated differently as opposed to some of the high crystalline polyceramic materials. So we discussed surface treatment of zirconia last time, how it was different on the 3Y versus 4Y and the 5Y materials. So getting into and deep diving into the resin bonding. So resin bonding actually is ideal for silica-based glass ceramic materials, and which has been well documented with long-term clinical success in the literature. Whereas clinical recommendations for resin bonding of high-strength crystalline ceramics such as zirconia mainly rely on in vitro studies, and see how I underlined it over there. So we heavily rely on in vitro studies, and I think this is going to be the main rant we are going to make today. But I will leave the ranting and raving to the experts out here. Moving on to the next slide. So this is a critical review article by Blatz and team that was published in 2018 in Journal of Dental Research, and basically it critiques several clinical studies published on resin bonding of ceramics, but it also discusses both glass ceramics, silica-based, alumina-based ceramics, and then the zirconia ceramics. And looking into this critical review, we can say it's recently published. So as at the time of publication of this review, the long-term clinical studies existing for glass infiltrated alumina were quite a bit, as you can tell. Densely sintered alumina, there was a retrospective study done by Sorrentino in 2012 that investigated the thin implant supported crown. But today's topic, we are not interested as much as in the glass infiltrated alumina, but we are interested in zirconia. So looking at long-term clinical studies at the time of publication of this review, these are some of the prospective and retrospective clinical trials. Retrospective studies, and let me put it this way, prospective clinical trials, and mostly they are based of resin-bonded fixed dental prosthesis, and a very important publication comes out from the group from Germany, Kern et al., and they did several publications and have data up to 10 years of long-term systematic investigations into bonding of single-winged RBFPDs, and we'll deep dive into that publication in a second. But just to get your attention, there have been some prospective studies looking at fixed dental prosthesis of zirconia with a composite resin cement and a self-adhesive resin cement. But at the same time, framework fracture was the main mechanical complication observed, and not so much has been investigated for a tooth-supported crown except for one retrospective study that investigated a zinc phosphate cement and self-adhesive resin. That was done in 2012 as well. And then out of that study, as you can see from the table, 12.5% debonded, 6.6% also debonded. We have to deep dive into that paper. Sorry about that. Okay. Then deep diving into this paper, which is a 10-year outcome of zirconia ceramic cantilever, resin-bonded fixed dental prosthesis with single wing, and the influence of the reasons for missing incisors. We are not interested in the reasons of the missing incisors, but we are interested in the 10-year outcomes. So this is probably the best you can get in terms of a long-term clinical evidence paper for zirconia, believe it or not. This paper is based off of 87 patients and 108 RBFDPs, all single-winged. Observation time was 10 years. 6 debondings and 1 loss of restoration was observed. And so this paper concluded the 10-year survival rate of 98.2% and 10-year success rate of 92%, so which is pretty great. There's another paper by Matthias Kern that actually talks about bonding to oxide ceramics, such as zirconia, and then compares the laboratory testing, which we are heavily relying on, versus clinical outcomes, especially when it comes to partial coverage restorations. There is no short, mid, or long-term clinical evidence or a prospective trial investigating the resin bonding to inlays, onlays, and veneers. Are people doing it? Yes, and that's what we're going to rant about today. So recommendation based on these published clinical trials. We also discuss the in vitro side of it. We know air abrasion with 50 microns alumina particles at 0.1 to 0.25 MPa pressure creates a good surface for bonding, and then an MDP or 10 MDP containing monomer or a ceramic primer will give you the chemistry or the chemical coupling for bonding to a zirconia surface. And then you can use any luting resin cement to create that adhesion between the restoration, the zirconia restoration and the tooth. This again is from the Blatz paper in 2018. As you can see, this limited scanning electron microscopic imaging, I must say, investigates without any surface pre-treatment. The resin zirconia bonding interface reveals wide open gaps and only limited adhesion. And I think you can see my cursor over here. So that's the gap that you see. And then the second image on the right, you can see that air particle abrasion of the zirconia surface with alumina particles at 50 microns, 2-bar pressure, and application of a 10 MDP containing ceramic primer actually gives you a adequate chemical bond, we can say, an optimized adhesive surface as reported by this paper. Then moving on, let's rave and rant. So the resin-bonded FDPs single retainer show the long-term clinical success, and that has been published in a 10-year outcome study. Great, we can rave about it. But the problem is, I'm going to rant a little and then leave the ranting to the experts, that there is no long-term clinical data for resin-bonded partial coverage monolithic zirconia restorations, and I underlined it again for you, such as inlay, onlay, or veneer. So who generates the clinical evidence? We do, but do we have it yet? We don't. So that brings me to the question of this episode. What are the current trends of zirconia partial coverage restorations? And from this, here I I would like to end my literature review segment and off to the experts for raving and ranting. Thank you for your attention.
Well, that was great.
That's amazing.
Well done. Maybe I'll start with. Let me share the screen, okay? Because I had a couple similar slides I dropped into something that might emphasize. Hang on a second. Let's see. So I'll need to share the screen. So this was an interesting paper, and you touched on this a little bit. So this is the only real meta-analysis I could find of, let's say, zirconia bonding. It has a little alumina stuff in there, okay? So where it's a meta-analysis of clinical papers, and it used single wings or double wings or whatever, but that's still adhesive, okay? And like you said, there's no real great data out there on inlays, onlays, or crowns that any of us could find. So here was an interesting thing. Now, Matthias Kern is one of the pioneers of zirconia bonding. So he in two 10-year studies, two different studies, he had zero failure of the bond. Now, he did have some failures because the wing cracked or zirconia cracked or alumina cracked, whatever, okay? But that's a different problem, okay, that it overloaded the prosthesis. But let's look down here at some other people. Gallus, Stados, or Sassi, or Irina Saylor. Okay, she had 13% debonding at 53 months, a little bit over 4 years. Somebody else had 46% debonding over 12 months. Okay, so what that basically tells us, and they've all followed protocols that we all know, we've sandblasting, everything was either sandblasted or Rocketech, so that the variability is extremely high among the studies. So you have one author that had zero, and so maybe he's got the technique down, and maybe if we looked at his preparations, he put some more macro-mechanical retention in, all right? And so what we see is we don't see this kind of failure with etched ceramics. It just doesn't happen. I mean, the reported failure rates are 1-2%, maybe, if that, okay? Fracture, that's a different issue. All right, so really, here's what's happening, okay? So we might as well go into this right here, okay? All right, so what I did was looked at different surfaces. We've done some stuff on this over the years, okay? So let's just go ahead and do this right now. What should we do on the internal surface? Now, John Burgess, and I was part of this et al., looked at the distinction between how much of bond strength would come from just the chemistry of the MDP primer and how much would come from the sandblasting. And he found that roughly 30% better bond strength came from aluminous oxide. But this was on machine surfaces. So machine surfaces already have a little bit of roughness. So I was very interested to look at what happened between a smooth surface, and I'll just fast forward to that right now. Just some other stuff we did over time, okay? So what we did was we polished zirconia surfaces and cleaned them very well. So they were super clean, okay? So they were polished to 2000 grit smoothness. And then we put MDP primer on there on 4 different companies. I don't want to beat any of the companies up right now, okay? And we looked at, and then I put cement on there. And we looked at, okay, the cement or composite with an MDP primer, but with no sandblasting. The average bond strength of the 4 materials was 4 megapascals. We had several specimens that popped off. They were 0 megapascals. You breathed on them and they popped off. So the chemistry alone is giving, yes, it's giving some bond strength, because if we put zinc phosphate on a perfectly smooth surface, or glass ionomer on a perfectly smooth surface, it would blow off too. So there was a little bit of bond strength. I said, okay, now, so that was pure smooth. That was different than what Burgess did as machined. As machined, we're going to get pretty much what you're going to see here, okay? So then we looked at it, said, okay, and we looked at 4 different materials. We made 6 specimens each. We threw out any variables that maybe we screwed up or something, okay? So then we sandblasted the surface of zirconia, just looked at the flat surface of zirconia, and then no bonding agent, and then just put the cement on, or could put composite on. I looked at the composite cement. They basically behave the same, where we condensed it through a little hole. I'll show you the video in just a second. All right, about 7 megapascals, plus or minus, down to maybe 4 or 3, and up to 10 or 11. So there was a fairly wide range. Okay, then the third group was classically what people would do. They would sandblast, put an MDP primer on, and we got roughly around 15-ish megapascals, plus or minus. Some of the specimens up around 20 megapascals bond strength, okay? Some of the specimens may be down around 10. All right, then I thought about this, and this is the way I've been doing it for years. If I'm going to bond zirconia, is I would do the sandblasting, clean the surface, of course, then put the MDP primer on. But the MDP primer, I was a little bit concerned, didn't completely wet the surface. The MDP primer bonds to an oxide on one side and bonds to a resin on the other side. So I just put a low viscosity resin, so just a regular bonding agent that you'd put on the surface of your glass or surface of a tooth or something like that. Then the cement on the top. That got the best bond strength. So we were up close to 20, 19, 18 megapascals. All right, so now here's the super interesting thing, was it was 100%. Every one of those, all four materials, it was 100% failure or adhesive failures. So in other words, it just pulled the bonding agent off. Now, Anvita, I do need to get you these specimens, and we'll work on that, because clearly if we look at it in an SEM, we might see a little thin layer of resin. Okay, but visually and under a microscope, I didn't see anything but zirconia, maybe a little tag or two of resin. All right, now, great. Okay, so what does that mean relative to what we've already had before? Okay, we've had glasses, right, that we etch, whether it's be a porcelain, a glass ceramic, Empress, or Emax. And so I did some specimens of everything, but I got all four systems with Empress blocks, okay, which are around 150 megapascals, pretty strong stuff. But it's etchable with a hydrofluoric acid. All right, now, we already saw this, okay, it was 100% failure adhesively. All right, so I think it was 8 or 10, I can't remember off the top of my head, but it doesn't matter because we got enough specimens and we saw the behavior, okay? This was going to turn into a full paper. And the reason why I can't give you all the exact numbers is because Anvita is going to be doing the full paper on all this data with really, really good statistics. But with your eyes, you can see some of these things. So the interesting thing is we were up around 35 megapascals on the etched Empress. Very similar on Emax, okay? So they almost behave the same. But fascinating. Here's the complete difference of what happened. The specimens ripped out a piece of the glass. That's true bonding. So when we're having an adhesive failure, is that really bonding or is that just really good cement? Okay? All right, so let me just show you here what I mean. Here's what the specimen looked like on the zirconia. Nothing was attached. So here's a close-up view of all of and this was using all the steps I just said. The zirconia, the sandblasting, the MDP primer, the bonding agent, and then the cement, okay? And we use an ultradent shear test. You don't need to see all the stuff, but we bonded a rod on here. We sheared it off on the side. I could show you a bunch of videos later if you're interested. All right. 100%. I mean, yeah, you could microscopically see there's a little adhesion. Let's look over here. I got fun. I just put a video in here because I want to rotate that so you can see that.
Out the Emax, or Empress,
It totally ripped out the glass. There was no failure adhesively. And the 20% higher bond strength, okay? Now, yeah, we've already seen all this stuff. So here's the point. Let me go ahead and back out of that, see if there's another slide I want to show you here. So I do not believe that we have true zirconia bonding. I am not quite sure where all this stuff is coming from. I'm reading these numbers. I read in a Gordon Christensen CR newsletter, 70 megapascals in some specimens. I'm not trying to disprove anything, Miguel. I know you're not either, and I know we're going to rant about this in a minute. But we all hear, and I realize this is pure anecdote, okay? We hear across the board when we're talking to people that are good clinicians, they're still occasionally having some zirconia crowns pop off, even though they're using an MDP primer. Well, now we see the reason why. Truly,
the problem that you're having is that you're still listening to Gordon Christensen.
Yeah, that could be true. Okay, that could be true too. Okay, and yeah, I mean, let's face it. Okay, so but the other side of that, I just showed you. I mean, I could show you about 100 specimens that it was 100% adhesive failure, and so that makes sense. It makes sense to me that most of the bond strength in zirconia is coming from at least half, not just 30%, half, maybe 60 or 70%. Is coming from the sandblasted surface. And we showed that last time, and Vita showed that last time, that you get, even with a 3Y material, the surface is a little bit rougher. Okay, after you sandblast it, the 5Y is definitely rougher. Nothing like etched glass. So anyway, now I'm also looking at a new material, by the way, that we'll get some data. It's over here on my desk, that we're going to pre-etch the zirconia prior to sinter it. So we'll get a nice rough surface, and I'll let you know how that's going to do. So anyway, so let's just summarize then for the audience that's watching. Yeah, you should be, if you're using zirconia for a short clinical prep, if you're using zirconia for a non-retentive prep, which I don't believe you should do anymore, okay? But you should put some macro-mechanical retentive elements, maybe a mesial and distal box. If you're going to do a veneer, maybe a mesial and distal groove. If you're doing a lingual wing for a Maryland bridge, a depression in the cingulum, maybe a little box form, okay? And then I think you should sprinkle some holy water on it when you're done and pray, okay? Now, the other side of that, you could say, is the worst thing that's going to happen, it's going to pop off. We don't see too much fracture, but we did here. We saw a little fracture in this paper that I was showing. So to me, I mean, we just don't see glass ceramics break. I'm not seeing it monolithic. Yeah, okay, you can hear somebody out there tell you one or two broke, but nothing like the debonding issue with this material. So to summarize, and then I want you to jump in, buddy, my Rantbro out there, is that if you're doing minimalistic, non-retentive preps, it should be some form of glass. And the only decision on which form of glass is the strength that you need. That's just I think that's an absolute today. And then beyond that, okay, bridges, yeah. Okay, for zirconia bridges or a subgingival margin on a second molar.
So as a moderator in this, I want you guys to define, because for me personally, you were talking Maryland bridge, single wing bonding. So then what's your alternative material in that? Are you going to do it out of Emax or something like that? Okay. Pressed ceramics? No. So you got two different categories. You got a single wing Maryland, and you've got partial coverage restoration.
Well, I just jump in there. Let me.
I agree with you.
So I kind of like the idea of zirconia for a single wing or a double wing. In fact, he had less failure with a single wing because it moved, if you looked at those papers. But here's what I would say. Don't rely just on the retention. Put a groove interproximal on the tooth that's getting the wing. Put a cingulum depression in there. So create a little macro-mechanical retention in your preparation, okay? And that's obviously if you can't do an implant. I mean, the treatment today is an implant, but some situations you can't. Maybe a 16-year-old or something like that.
Well, there's a big trend going away from anterior implants if you can do a single wing Maryland, because you have a way better recovery long term. I mean,
I got the evidence right there. That was 5 years ago.
Yeah, I'm good with that too. But just the moral to the story is, the moral to the story, you're gonna sandblast, you're gonna use an MDP primer, you're gonna use a bonding agent, and you're gonna put some retention in your preps.
And I think,
no, I can't go with that. I'm sorry.
Yeah. So let's get our Rantbro in there.
I'm sorry. I can't follow you on that one. I can't. I have to push back.
Okay.
On your resume. First of all, Anvita, amazing, really good. How you showed us that, hey guys, girls, all of you who are doing onlays and overlays in the posterior of zirconia, there's no data to show that it even stays.
Yeah.
And then Ed coming in and showing, and we've been doing some research, he says, and this zirconia bonding has some questions. I don't think we're bonding. And that leads to the potential problem that we want to discuss is, what do we do when we're using zirconia, now knowing that there is not enough research to support its bondability, and we have these anterior things that are debonded. And then and here's where I depart with you, in these scenarios, put some retentive features by grinding any type of thing on the tooth. And at that point, I'm like, whoa. I would like to go back and discuss, why are we using zirconia in the first place? Why do we always have to hurt the tooth because we are choosing the wrong material?
Okay. So let me explain.
I'm totally happy with an Emax number 7 bond restoration. And not only that, I did this the last at least 4 or 5 times. This is how much it is. Usually there's a mother you're talking to, because this is a 16-year-old, right? She just came out of braces and now is ready for a sting. So I'd say to the mom, well, this is the price, but I would also recommend you to, since the lab has to do 1, let's make 2. And I only charge you the lab fee, but you take the second one with you. And if anytime anything happens, use the second one.
Right.
And everybody leaves happy. and there is no implant that's going to look like 2 miles away from the roof of the mouth in 10 years, and it can be done totally out of image. So the reason I'm so passionate about this, because I'm not really too concerned about the anterior restoration breaking. That's 1% of what we do. But all of the dentists who are trying to do minimally invasive in the posterior, and they finally take the courage to do a bunch of onlays, they start doing it out of zirconia. It doesn't work. They believe that they need retention and resistance forever, and they go back to prep for crowns. So on that aspect, I would like to join the wagon of, zirconia bonding is not even close to glass ceramic.
Absolutely, it was double. I'm giving you the numbers, and then let me just throw something back here. I just used the study because that's the only one I had on a meta-analysis, okay? So that's a very small amount of cases that anybody ever do is a single-wing Maryland, okay? But your point exactly, I'm 1,000% on the same page as you, Miguel, is I don't believe we should be doing inlays, onlays, crowns that we have access that we can bond the margins, okay? I think anything probably anterior to, and including the first molar, out of a glass ceramic, a high strength. Okay, maybe our second molars where we can't isolate, or for sure bridges. So yes, you and I are on the same page. So let's not focus on that Maryland aspect. And then we could argue about whether we would do what I said or what you said there. So clearly the data is showing that, and clearly the anecdotal reports from everyday clinicians out there about zirconia falling off as onlays.
I will add two things, and then I would like Richard's opinions on this one, especially the first one that I'm going to mention now. There's a mismatch of modulus of elasticity that we cannot ignore, especially if you're sitting on dentin. So that forces maybe from zirconia to dentin sent to the bonding layer. And the other one is, at least I don't know, I was going to say we don't know. I don't know what the surface of zirconia, the integrity of the surface of the zirconia that I just sandblasted by force, what it is. So we might actually be getting good bonding, and the zirconia might have, to put it to the extreme, after you sandblast, like a smear layer there. You just blasted this thing. It's not the same as etching. Etching, whatever you dissolve goes away. Whatever was untouched, it still remains there. As maybe what we're having, is that we don't understand what's going on with this zirconia sandblasting. We just think that it's creating this roughness, right? And maybe it's weakening it at a first, layer part, and maybe that's what comes out. So you see clean zirconia. I would like to see on that resin, when you say clean zirconia, is there any, thin as nanometers layer of zirconia here?
Right. Yeah, we're going to look at that. But the point being, the bond is still a lot less. There's still a lot less.
Something is happening for
fail that. To fail that. Okay. Yeah. It's less than. It's a half. It's literally half, and and on multiple specimens. So that's significant. It's not like 10% or 20% that we could explain away by other things. It was literally 100% difference. Okay, and again, we go back to the clinical reality of, and we saw that in those papers, the amount of failure that we see clinically.
So Ed, your friend, you have a nickname for him, Taser? What
Taser Suleiman. Tazier.
Suleiman. So
yeah.
Tazier presented at the Curare KOL meeting in Florida in December. One of the things that Taser brought up that was really interesting, and I think he would be the perfect guy to actually bring on for this subject, because he's the most thorough lecturer I've heard in a long time. But he brought up a point that they now have a correlation between because a lot of doctors don't have air abrasion. So they're having the labs air abrade, and they were able to show that there's a decrease in bond strength with zirconia to do with the time frame of when you air abrade it. And it's
I'm going to rant, Richard. That is irrelevant. Okay, I'm telling you, I did it, but then they're going to get less bond strength than I got. Okay, they're going to get less bond. So my point is, there's a doubling. Half the bond strength, and I did it perfectly. Okay,
no, I'm not arguing
perfectly. So it doesn't matter that it gets lower. Okay, it's already super low. That's what I'm trying to tell you. Okay, so the fact that testing, that's great. I appreciate that. Okay, so on top,
and I'm gonna round.
Yeah, go ahead. Okay, please do.
Just for a minute, I'm the moderator. Let me rant.
Yeah. Well, the moderator's not supposed to rant too much.
But all I'm saying, well, this is an area I deal a lot with. So what I'm saying is we already know the bond strength isn't anywhere near glass ceramic. So with that said, we better get every bit of bond strength.
Absolutely. That's my point.
Air grade within 5 minutes of cementation.
Okay, so excellent point, Richard. Looking at it that way, that's an excellent point. So if you're going to choose to do this and you want to get this 19 megapascals that I'm talking about, and that's the best I got. Okay, a couple of them were 20, 21, 22, but nowhere near the 35 some people are reporting. Nowhere near Gordon's 70 that I saw. I mean, nothing like that, okay? Okay, so then the other point on top of that is there's other things that'll even take it down from the 19, all right? If you don't sandblast it well. Okay, if you contaminate the surface. By the way, I'm looking at those other agents. I'm looking at the zircon and the Ivoclar material to see if that makes that big. Yeah, I'll report on that later. Okay, so absolutely. So okay, let's summarize and come back together. And let's get into a couple of other things. Okay, I think all of us believe here that if we have a minimalistic restoration, we're going to do some form of glass. That's just the best, and that's well documented. There is a ton of clinical research to prove all that, okay? Number one. Okay, number two, okay, zirconia for bridges. Absolutely. Okay, everybody's going to agree with that. Maybe a small bridge Emax, okay? So where we're lost now is that if you're going to choose, and we're not recommending that, so if you're going to choose to use zirconia for a less than ideal preparation, okay, for retention and resistance form, you need to do all these things. Not just, by the way, I used some of the E-cements. I forgot to drop that data in where there was no separate primer and then the cement. So the all-in-one cements, they were 20-30% less bond strength. So the all-in-one cements that have an MDP primer, if you're counting on adhesion, you're not getting it. Yeah, you're getting a bond strength better than zero. Okay, so that you want to use those techniques. And then Miguel's point is well taken, okay, is that realistically, we don't want to be doing that for adhesive restorations. If we're forced to, you want to follow the protocol.
So on that note, I want to throw it back to Miguel. Miguel, there's going to be a lot of people that are going to ask. Going to be just a second. There are going to be a lot of people that are going to ask, and I want you to elaborate on this because I agree with you. A pressed Emax single wing Maryland would be the ultimate from a bond standpoint. So, what are you designing in to that restoration for the other dentists out there who are going to go, well, I'd like to do some out of Emax?
Great point. How are you going to design that wing? Great.
How are you designing?
We're talking about the interior. We're talking about the interior, right?
Or the volume of
anterior from
or the volume out.
I don't overthink it. Like I don't know. I really don't overthink it. To say how I'm going to design the connector. The connector is going to be long. If I can get it. If I can get it from the gingiva to the roof of your palate, I'll do that. I mean, like, I'll do it as tall as I can and as aesthetic as I can, as I think that I can make it. I think any technician will always utilize all the space you have. So I don't overthink it. They usually come back pretty well. I think you guys will agree. Some of them stay, some of them don't. And there seems to be no correlation unless an obvious interference, right?
Right.
And what I do for real, when we have something in dentistry that we don't have a solution for, this is what it is, we should not hide that from the patient. So I talked to the parent and said, this is what's going to happen. This is a 50-50. I don't know. You might break when you come out of here. Like I've seen it break there and I've seen it last 20 years. And this is the limit of our understanding. So that's how I deal with it. And I don't spend too much time thinking of the small problems in dentistry, like the outliers, which is interesting when you teach courses that some students just like to focus on the outlier. And it's like, let me teach you how to do A.
Right.
Asking about 0.2, right?
Yeah. Yeah, and that is, coming back to that's a major point. Not too many people are doing that, okay? The one, since Richard brought up one technical thing, so obviously we want to get as much height buccal incisal gingivally as you can. What would be your minimum thickness buccolingually? Let's say that you're going to do a lateral incisor. What would you be thinking about? Because remember now the difference.
My minimal thickness will be, I'm looking at the parent, I'm thinking, are you a reasonable person or not? Because if you're not a reasonable person, I'm not risking anything on my end. No, sorry, there's nothing we can do here. versus, do you understand what I'm talking about? Look, this is going to be tight. Like, I am. You okay if you break? We'll give it a try, because the other option is the implant. We talked about that. The other option is a 3-unit bridge, which some dentists will tell you, please don't listen to them.
Don't do that.
So my connector depends more on who I'm speaking with, meaning what kind of risk I'm about to take. Because if they're willing to take a risk, I said, hey, this is just about money. Let's try it. If it breaks, okay, it didn't work. Right?
Okay,
and some people is like, yeah, let's go.
But
I try to make, I can go very thin sometimes if I feel comfortable that we're both understanding that we're taking a chance.
Okay. So and that, I think you're getting to the point. I'm thinking, but what, you're evaluating a case. Would you feel like, okay, I got only 2/10 space I can do buccolingually with a connector? Are you okay with taking off 2/10 of enamel if you just to double the life expectancy maybe?
On the lingual of anterior?
Yeah, that's what I meant.
Yeah.
Okay.
But
all right, guys. Well, yeah, go ahead.
So then on that note, why not go to 3Y, which is what I generally use, and have it with a layered,
Well, let's not forget that we can also do ortho. We can create space, huh?
Right. Okay.
We can create space. If what we're talking about is give me an extra 3/4 of a millimeter, if we truly want to do it right, that's 10 weeks of Invisalign, 15 weeks of Invisalign, right? I guess. So,
yeah, guys,
I have some to create space.
I'm a little concerned we're spending too much time on a Maryland bridge, which won't, because that was the literature but go ahead. But so
the reason, though, I think it's a good subject is because there's a lot of dentists who are putting in implants where we really need to be looking at single wing anterior.
That's a whole great topic. And Vita, you want to throw something in there?
That's a whole other day.
Yeah. So I think okay, let's summarize. Wait, guys, I'm going to moderate.
Chapter on that.
I'm going to moderate for a second. I think 100,000%, all four of us here, if our daughter was in the chair, missing a lateral incisor, we would do a single wing. Okay, that's what we would do. Okay, I agree with that.
So just trying to be the devil's advocate today, and the questions that I see in the student clinics, and also when we go out there, we see great cases on social media. People are advocating for zirconia veneers. So being devil's advocate here, we have no evidence. And again, building on to what Dr. Ortiz said, are we, without the long-term clinical studies and systematic following up these bonded zirconia restoration systematically, are we ready to bond zirconia veneers yet?
I do not believe we get a bond.
Okay.
All I can tell you is I have 3 that are bonded on because your buddy Ed wanted to do them that way, and they were done in 2016 with Panavia V5. They're still on, but I waited.
Okay, so having said that, you go remember the list of the papers on the single wings. Okay, 8%, some of them had 8% failure rate over 2 years. Some of them had 46 over 1 year. Okay, so if you do things perfectly, like you said, tasers work. Okay, you do things perfectly. Okay, you're probably going to have a very low failure rate, but you're still going to have a failure. If you do enough of them, you're going to have failure rates much higher for bonding, significantly higher than you would for an etched glass. That's the point.
No, I mean, I only have 3 out there, and those are the only 3 I've ever done and ever plan on doing.
Yeah, and, interestingly, I did a whole bunch of Procera and Inceram over the years, and we were taught we could bond it. We sandblasted it. It was 7 or 8 years until they started to fall off. We sandblasted using an MDP primer. So let's just summarize. Well, we're going to leave it with that you get roughly half the bond strength basically of an etched glass, and that, yes, it's 18 megapascals. That's nothing to sneeze at. That's a lot better than 0, okay? But we aren't getting true adhesion like we believed we should get if we're bonding to dentin correctly, if we're bonding to enamel correctly, or if we're bonding to glass correctly. All right, guys. So that was yes, please throw something in.
But one last thing I want to throw out there, just based on the slides that I did. The first question I posed, and that's the question of the decade or over 2 decades, is if we have a good retention and resistance form, do we bond or do we cement a monolithic zirconia crown, because we are in the age of the monolithic ceramics, or at least monolithic polycrystalline ceramics. And then the question still stands, if we do not have the retention in the resistance form, do we bond or cement?
Okay, so that's a great question. So that's another thing. Do you routinely bond something just because you can? Okay, even if you if you got plenty of retention and resistance for them. I think the literature is fairly clear today. I would seal the dentin somehow, okay? Because you're going to get less micro leakage between. I just believe that, and I think the literature is kind of clear on that. So now whether you use a conventional glass ionomer on an extremely well-fitting crown or you want to go ahead and bond it, that's up to you, I think.
Right. And I think
I don't think we have a 100% answer.
That if Dr. Young would agree, if we have a Panavia V5 in the drawer, why not use it, right, instead of an RMGI?
Correct.
And he winked at me.
I've been using Panavia. Why market it? Right.
Okay, I knew I would get talking.
Well, the other side of that, Richard, then what do you do toward the tooth? Okay, are you just using the V5 by itself and nothing on the tooth?
No. Well, the V5 itself is a bonding system built in.
Yes.
So it's a little different. So the earlier Panavias, if we wanted to increase the bond strength, we added a bond layer. But now with V5, you have your tooth primer, which is the bond built in. So think of it this way. That's the difference between 21 and V5. V5 has, and a lot of people's light bulbs went on when this happened, is the MDP is in the cement and the bond. And when those two come together, there's a chemical reaction. If you've heard Burgess talk about this, you can't pull V5 apart and put it back together. You'll lose your bond strength because there's a chemical reaction going on between the two components.
So you put the bond on the tooth. Do you put the bond on the
primer? That is the bond.
Yes. Okay. Right. Okay.
And then in the crown itself, and it comes together.
Okay.
Whereas before, the MVP was, well, you have your silane, your primer, your porcelain bond activator is going on the restoration with MVP in that.
Okay, you should not put silane. Okay, let me stop you. You do not want to ever put silane on zirconia. Okay.
It's the porcelain bond activator that comes with the V5 that is designed for zirconia metal composite, right?
Yeah, but that's an MDP primer.
It's an MVP primer.
Yeah. Yeah. Okay. Yeah. Not a separate.
That's why V5 is a lot different than the 21.
Well, we covered a whole bunch of stuff there, guys. I'll kind of jump in, and I think that's very good. I don't want to overwhelm our audiences too much, okay? So what I would like to do at this point is let's shift to a couple of positive things that you like, a couple of raves, anything new and fun you've played with that you really like today, and I'll put that out to all four of you out there. So why don't we start with you, Dr. Miguel?
I have a little rant today, and because our topic for the last two episodes have been zirconia, and very much deserved so, because it's a big part of our profession, restoratively in the last 15 to 20 years. And to me, the problem that we're having with zirconia is what we have talked in the last two episodes. If we should use it or not, what are the indications, what are the pros and cons, blah, blah, blah. How we're trying to find out that it's not as good as we thought it was in many different ways. And even though we can complain and say, should we use it, should we not use it, what happened with the Maryland, what happened with the Only, with the Crown, I think it shouldn't be used at all, except for some ridges, as we spoke. The reality is that this problem... No, but hold on. The reality is that this problem comes out of a bigger problem. So it's not the problem itself. It's a symptom of a bigger problem. And that bigger problem is the fact that we say that we are a medical profession, but we're not. Because a new product come out and we decide that we're just going to try it. Let's see what happens. Hey, look, can you do 3D printed crown? Let's see what happens. Hey, here's zirconia. Let's see what happens. And in 10 years, we'll see how many patients lost their crown. Let's
right.
Let's just go. You don't do that in medicine.
Right.
You just don't do that in medicine.
Right.
In medicine, first you need to prove that it works. And then we're going to decide as a group if we're going to allow it for you to use it on patients. So I think zirconia comes from that problem, from the problem that we think that we can test on patients. Change cement. Oh, let's just change cement. Which cement do you? I don't know, whatever.
Yeah, I think there's a lot worse things than zirconia. One sentence that you flew by that you said, what very soon I'm testing right now the 3D printed materials that they're selling for crowns. We're going to do a whole episode on that, and that I'm very, very, very worried about that. Okay, Dr. Rantbro. No, I mean I love that. No, that's awesome what you just said. That's awesome.
But for us, we if you follow your numbers, if you read, it's like, 100 failures out of 1,000. That's 100 patients that had to go back to the dentist.
Right.
But the dentist probably charged them again, never took responsibility. Sometimes because we know and we don't say, or sometimes because we don't know. To me, they're not numbers. To me, it's like I'm tired of us playing that we get to test anything.
Right. I agree.
Like,
I've come from that opinion. I'll tell you what I tell people, okay? And you may agree with a little bit of it at least, okay? Is that if you're going to try something new that's just brand new on the market, if you use it, or how I would try it even at a university, is that if it did not work, I did not limit myself to any previous option. So I've just lost a little time, okay? So that's how I would think about that. So much stuff makes it to the marketplace with a 510K. And let me tell the audience out there something interesting. I know you all know this, is that the 510K, most companies want to get through the FDA on what's called a 510K process. And so what they do is they go to the FDA, and here's what the process is. You go, Mr. FDA person, Mrs. FDA, says, I'm going to sell a material in the dental space that's basically the same as something that's already out there. It's already being used, and it's already successful, okay? So and the FDA says, oh, prove that to me. So however they prove it to them, they do, and they give them a 510K approval. Then they turn around and tell us, the dental public, I got this brand new XYZ 3D printable crown stuff that the FDA says it's a crown. It's a ceramic even, okay? Boy, we're going to get into that. I can rant for an hour, okay? That'll be a new rant. Next.
It's a ceramic that you surround with resin.
Oh, my God.
It's a ceramic that you surround with resin.
We're going to get into that, ceramics and resin. So anyway, so there's so much disinformation. I wouldn't say it's fraud, but I would say it's damn close. Okay, and so beware of that, please, end user out there. And I would tell anybody, don't use anything that you don't know anything about, or only a salesman's tried to tell you something, until you get at least some reputable university person say, hey, I've done 20, 30, or 40, and here's what I see. Okay, and these newsletters, I really worry about these newsletters. I don't care what they say that they're nonprofit. There's money being going in certain different directions. That concern me, and I'll leave it at that. Okay, let's give a rave, guys. So Richard, throw me a rave, buddy. You gotta throw a rave on that.
I've got no raves. I'm tired of looking at heavily diffused.
Yeah. Well, any cool little. You guys are both phenomenal photographers. Any little cool photographic toy you tried recently?
Yeah, I'll show you cool. These are trick bit out of England.
Repeat that, please.
Trick bit out of
okay.
England. Chris Orr turned me on to these years ago, but we had to put silver. Now they've created, as you can actually take the Nikon ring that a lot of people have resisted,
right?
And with these trick bits, you can angle them any way you want, and you get an absolutely gorgeous lighting for like $42. Or maybe yes. So I just they work.
Yeah, share with the audience what's the improvement over of not having them. What do you see in your image?
So for imagery in my office, if I'm doing anything anterior where I really want to see detail, which I'm seeing is not happening, I'm just using the polarizer over my flathead like you use.
Yeah.
So this is my anterior work, all anterior shade work before and after.
Okay.
And I go to the posterior where I'm wanting to get a really pretty photo, but I want to get the light in there with twin flashes instead of a ray, which gives you a nicer look.
Yeah.
These little flashes, and these work great in the anterior well, too. They don't diffuse it as much as your light boxes and all this stuff we're seeing. So you still get really nice accuracy with these. You still see anatomy without washing it out. And they're really cheap. They're easy to use. They literally they pop on and off really quick. So that's just something that I rant about all the time. They're on and off in a minute.
Okay, do me a favor. Send us the link for that, and we'll have Armando edit it in on the thing. And Vita, throw up.
Only they send us some to test.
Okay. Well, I'm sure we can get some. We for sure. No, I mean we should test.
You don't need to test them, man. Come on. I bought like 4 sets.
Okay.
Cheap.
Oh, come on. Well,
I mean, I'm working out of this garage manufacturing. Want to give us?
At least to test. Okay. Well, Richard, you're speaking from experience. Miguel and I are very careful, and I know you are too.
Why it's not recommend I buy it and I try it, and it works.
Yeah, but I mean, there's a million things out there that are $40. Okay, that if we're using them,
I wasn't gonna test it. I was gonna use.
Okay, and Vita, give us a rave.
Give you the excuse to get it for free. That's all.
I think I'm the moderator now, guys. I'm gonna, and Vita, let me give us a rave out there. Something cool that you've tried, or something that you would recommend to our dental audience out there.
The rave would be that glass ceramics are time tested, and I am a big believer in what I see, I do, and the numbers look great. So why are we trying to pursue something that Miguel said we don't have to pursue because we have a material that works? And I think we have had enough rants today, so I'm not going to rant about the 510Ks and the big issue that you have brought up, that how some of the manufacturers are actually trying to circumvent the clinical trial route and just proving the material to be a certain chemistry to non-dental people at bigger positions, and trying to sell something that is not meant to be sold in that category.
As you have rants pop in your head that we can't get to, write them down for future visits. Oh, okay, Dr. Miguel, well, I want you to finish. I know it's tough for you, buddy, but give me a rave, something cool that you've tried.
I'm very happy about something, and I wanted to share. I'm very happy about the fact that there's a resurgence for glass ceramics.
Okay.
We got that profession. I'm very happy that the profession is finally taking the turn on closing this zirconia last 20 years. We spent so much time, so much research to end up with something just like Emax or Suprenity. I'm like, with 2 decades we wasted. So I'm so happy for you. I'm not being ironic. I see it coming. I see it happening. Now that we're teaching and people are learning how to bond on the posterior, how to prep on the posterior, now we can understand just bond a ceramic in the posteriors. I've been full ceramic Mark II Forte for almost 6 years. I did one today. I finished a full mouth all out of Mark II posteriors. Like I delivered and I bonded it. Like I don't think of glass ceramics when the prep is well done and the concepts are understood and they're bonded as something anything less. Because for a time it's like, oh, it breaks. No, it breaks because we weren't bonding and we weren't prepping right. So we need to get the people away from thinking that glass ceramics are weak. I know they've been proven to work, and I'm happy with that. That is a rave. I can see it turning. Pretty concerns me because there's going to be a humongous financial incentive to use it. But I can see that we're putting zirconia behind, and that puts me happy.
Right. Hey, that's a good point. So put down on your to-do list, Miguel. So one of the next 2 sessions, I think that would be great because you've tried them all, okay, and done a lot. Is that you give us a short 15 or 20 minute lecture where you would use Vita block, where would you use Suprenity, where would you use Emax, give a little bit of treatment planning, pros and cons. So that'd be great for our audience out there. All right, so
put in the preps. A lot of doctors have, you see so many different prep styles, and Ed and I come out of a ceramic world from the 80s. So show your ideal preps for these.
Absolutely, yes.
Yeah, we can discuss. I mean, I've been posting. I know you guys have been commenting on it. I've been posting. So I was laughing. I was kind of laughing internally when Richard was showing how he's taking pictures. I went through the whole process of pictures. I think like most people do, you guys too, in which I got to be really good at it, which anybody can. I got to be really good at it, and then eventually I'm like, you know what? I'm done. Like I'm done. Like who am I trying to show off? So it's that I don't use the big diffusers anymore. I removed my flashes from my cameras. I have 2 tiny little, speed lights on the side with a diffuser. So now my camera is free. I just put those 2 things next to the patient with a tiny diffuser. And I'm not looking for the Instagram photo anymore. And I started showing my preps on the CEREC when I'm designing. Here, right. I show you the thing. And so here's the prep. There's an unedited picture. Here's the prep, and I do it. So I'll be happy to walk people to some of the content.
Boy, we're getting some good future content. So, in fact, that's a great point that you make about cycling through all of the toys with anything, okay? And getting to what the minimum works extremely well. So I'm going to have you two guys at one episode in the future do a kind of a tag team photography, a little awareness. All right, so we got one last thing to do, and then we'll get to our interview, is we're going to go over a few questions that we've gotten from our viewers over time. And viewers, please send in questions to either Miguel, me, or Richard, or Anvita to one of our social media sites like Instagram or Facebook that we can get in the future. All right, so good. Along this lines here, and this will be an interesting answer to this question. I've done both, what the question is, and I'd be interested in what your thought process is. So what's better, palatal veneers or... which then obviously do the facial too. So that'd be two restorations, one on the lingual, one on the facial, or taco shell. Okay, where you kind of go wrap over like a taco shell. And I'm not sure who coined that, but I've done a few of those over the years. And that question was
my lady will be upset if you don't give her credit.
Well, I think she's maybe one of the first ones to talk about it, to write about it, but I can
I'm not saying she did. I'm saying she'll be upset if you don't say that she's the one.
She's the one that what?
That coined the taco.
I don't know. Okay, I'll take your word for it.
She says openly.
Yeah.
Oh yeah.
I actually heard it from Bruce Crispin. I got to tell you, in probably 1985, 1986. So yeah. Okay. I mean, Bruce Crispin. Bruce Crispin was one of my mentors at UCLA. Fabulous dentist, a little bit of an issue of a guy kind of like me. He showed. Kind of like nutty. He's a little more controversial than me, okay? But he showed us a case, and I thought that's cool. And this was 1986, okay? So anyway, whatever, it doesn't matter, okay?
No, I'm not saying the procedure. The name taco. Show the name taco.
Okay, all right. I'm just okay.
Who came up with that? Can you repeat that, Miguel? Who came up with it?
Francisco Vallardi. Francesco, sorry, okay. I'm just telling you, I heard about it from Bruce in 1986, the term, okay?
Yeah, so, and I think in the early years, a lot of us said things, but we never thought about pointing them. You just throw it out. It was said there.
And there's an interesting thing is
we're going to become the moniker of our history.
Yeah, this is a good rave right here, a good rant right here. You know, there's another interesting reality, okay, and they've proven this through scientific studies that sometimes there's a convergence on thought. When people are thinking about minimalistic restorations, several people around the world come up with the same ideas at the same time, okay, without input from everybody else and add to it. So it doesn't matter at this point. Okay, so Juan Delgado Sanchez asked that question. Okay, so basically you got two designs. Your lingual's gone a little bit, your facial's gone a little bit, your interproximal's okay. You don't need to take that away. Traditionally, we do a full crown, right? Okay, one way to do it is wrap up over the buccal lingual that kind of looks like a taco shell folder, or the other is on the palate, you do a restoration, and the other on the facial, you do a restoration, okay? So they both work. Now, the only thing about doing the palatal and the facial restoration is you do two restorations. Are you going to charge for that? Now, there's one contention that I would make about doing the lingual and the facial. I believe Francisca teaches build up the lingual with composite. Okay?
There you go.
And then a ceramic on the then a ceramic on the facial. That's not how I ever did it. Okay? If we're truly using the word biomimetic, okay, and all of these people say they're biomimetic. What is the stiffness of enamel? Is it composite? No. Stiffness of enamel is around 80 gigapascals, okay? The modulus, the Young's modulus. The stiffness of composites around 14 or 15. So if I'm putting something flexible on the lingual and that tooth gets loaded, that's not going to help resist the deformation of the tooth. And if you have porcelain on the facial, the stress will go in the porcelain, trust me, and it'll crack. So here's how I would do it. And I did 2 or 3 cases like this, and I don't know that I would do that because I'd have to charge $5,000-$6,000 a restoration, facial and lingual, okay? So I would do a lingual Emax, bond the lingual Emax. And nobody taught me this. Maybe somebody did it before me, okay? So we did a couple, Anvita did a couple at UCLA. And then I would do a porcelain veneer on the facial, or I'd do Emax on the facial. If I had enamel, porcelain veneer. If I didn't have enamel, I would do Emax. So I think that's a mechanical mistake to put composite on the lingual. Okay, if you want to do it, then you better put Emax on the facial. You better put a high-strength glass. But if you're going to put a porcelain veneer on the facial, mechanically it does not make sense, and it does not follow with biomimetic principles to put a flexible material where a stiff material used to be. Now, the taco shell, cool, okay? That's not easy to do. That's not easy to hide in the contacts on the facial and the lingual, butt it right up to the contact, both the lingual. So if it was me, okay, I'm probably going to do, if I can, if it's not an undercut or open inner braziers, I'm probably going to do the taco shell. Now, having said that, if I've got open embrasures through and through embrasures, I can just do a very minimalistic preparation today out of Emax. Yes, I'm going to have to go through the interproximal a little bit, but I just put the lightest chamfer. So that's how I do it. What's your guys' thought?
I mean, I'm not going to argue with that on.
Oh, I will. Don't worry. If you want,
I know you will.
Oh, guys, now let's do it. So if you want to, that you're not going to be alone.
But I don't do them. I'm going to refer them to you and Ed.
Okay. All right, Miguel, give us your thoughts, okay?
Well, how close are we at? How close are we at? Are we close enough? Can I throw a punch?
Throw a punch, man.
That was beautiful. That was beautiful dental porn.
Yeah. Okay.
That was, like if you put a composite at it, the modulus and the rigidity, and it will transfer the forces through the tooth, through the bonding layer of the facial of the ceramic, and everything is gonna fall off. And I'm like,
I didn't say
what you have.
Fall off.
It's gonna transfer to the ceramics. It's gonna. Well, you say you better use Emax.
No. We did that.
Use Emax.
We did that. Okay, no. What I'm saying to you.
Let me complete it. I'll let you rebut. What the reality is that I'm trying for more people to be conservative. I'm trying to convert 99% of crown makers into veneer makers, and some of the veneer makers that I open in video wrongly, and then the veneers break because the occlusion is bad. I want to teach them how to do anterior guidance. So if I want to get all these people to do something good, how the hell I'm going to teach them to deliver buccal and lingual tiny pieces of glass? Just because there is a theoretical mismatch of forces, when what I can do is I can look at them and say, listen, have you done veneers? Yeah, I've done veneers. Have you done a lingual composite? Yeah, I've done it. Okay, you can combine them both. And the good thing about the lingual composite versus the ceramic comes from the lab. You and I know how to modify. I modified 10 of them today. But most dentists don't know how to modify a tiny piece of lingual ceramic. So whatever goes, they're going to have to bond. But if I get the composite, I had the best articulator in the world. I have the patient with me.
Right.
I'm going to mold that composite after I put it in the lingual to the anterior guidance that I need. So I think then your point is valid in the thought process of how nerd we are, but the implications of it is that nobody can do it, and composite works really well. That's my push.
Okay, yeah, so let's focus on we got two separate things happening here, okay? So I can show you where we did some studies where we bent a few things and where you're more into dentin, okay? And then you have porcelain veneer on the facial. Let's talk about it, separate this out, okay? The porcelain veneer breaks. It breaks. Okay?
The what was into dentin?
When we're missing lingual enamel. When we're missing lingual enamel. So basically we're into dentin. Because the stress doesn't disappear, okay? So I'm just answering the question, buddy, okay? So the question becomes, okay, so you're looking at a case where you got lingual wear, facial, but you got interproximal. We're looking at a case where we have perfect interproximal contacts, there's no caries, but you've got lingual wear, and you want to do something on the lingual, you want to open the bite, okay? So I have no problem with putting the composite on the lingual, okay? And now there's an issue with that. How many dentists can isolate and build up lingual normally? So you're assuming that they can do that well. Most of them can't even do it on the facial. Sorry, me either.
Yeah,
okay,
you can give a lingual of an upper anterior dry. Come on.
No, you got to do all the teeth though. You've got to build up. If you're opening the bite, you've got to do 6.
Oh, well, that's different. What you're saying is different. We're talking about lingual taco. I wasn't talking about a posterior. No,
but if I'm building up the lingual, you got to open the bite.
Well, obviously, probably you have porcelain on the posterior, like.
Okay,
sure.
You still got to do 6 teeth. Okay, So you got to open
do,
it, right?
yeah.
Okay. All right.
No,
So
I'm saying it's easy.
I'm okay with that. I actually.
It's easy. You think so? You think the one?
Well, wait a minute, boss. Boss,
you gonna isolate for delivering the porcelain veneers on the label? If I cannot isolate for the composite,
it's actually not that hard. I did it 3 times. Okay.
Oh, I'm not saying it is. I was just playing your thing.
It's actually. I think I believe it's easier for a dentist to cement a veneer than build up and shape the lingual. I absolutely believe that. Okay. All right.
Easier, yes, but which one can be done better?
Okay.
I have a question for you.
I think you could. I can think you do a thin layer of Emax and bond that better than you end up with somebody building up the lingual. Because look, all we got to do is wait. All we got to do is look. All we got to do is look at everybody's bonding. There's probably 3% of the dentist on earth, maybe you're part of those 3%, okay, that does bonding that holds up well over time. Because on the facial, now we're talking about lingual. Okay? All right, so coming back to the question, we're getting sidetracked, which is cool because we're getting a lot of different thought processes in here, okay? So what I'm suggesting would be is if you're going to do composite on the lingual, thinking like a material scientist for a second, putting that hand, then what I would put on the facial is a glass ceramic. Okay? I would not put a porcelain veneer on the facial, okay? Because of the dynamics of how the stress would be. And you're going to get a great aesthetic result, which I think we all agree.
Just to confirm, I don't know if you misspoke or if I have to change.
I could have.
Porcelain is a glass ceramic, right? So you meant...
No, porcelain is not a glass.
He made feldspathic.
A feldspathic, I would not put feldspathic hand-layered porcelain veneer on the facial.
So you don't consider feldspathic a glass ceramic?
No. Okay, by definition, a glass ceramic means, okay, really it's controlled crystallization.
I'm not criticizing you. I think if you know, you probably are right. I just want to learn it.
Yeah, I spent a lot of time thinking about this. In the ceramic literature, okay, in the ceramic societies, they call it controlled crystallization of glass. It's been dumbed down to a glass ceramic, meaning a block of glass that have crystals in it, okay? A block of glass that has crystals.
So Mark II is not a glass ceramic.
Yes, it is a glass.
Okay.
It is a glass ceramic.
But that is feldspathic.
But it's still, yes, but okay, let's differentiate porcelain veneer versus a glass ceramic veneer, okay?
So you're saying don't stack it. Is that what you said? No.
Okay, so we could get in a whole material lecture. The basic difference, okay, if I take Emax, and I did it, I ground it up into a little pile, and I made a porcelain, like porcelain. I made a porcelain veneer out of it, or actually made some disc, okay? And we fractured them. The strength done that way, ground up, built up, fired again, okay, was not that much stronger than regular porcelain. See, the difference is, here's the big difference between porcelain and a glass ceramic. Porcelain has a third phase. Glass ceramic has glass and crystals. Porcelain veneer has a third phase. Do you know what the third phase is? Air. It has air in it. Air weakens a material by 50%. Okay, so I'm just trying to differentiate here for a second, okay?
No, I'm asking you what the differentiation is, because I'm teaching different, that's why.
Okay, no, I think you and I are teaching we're teaching them the same, my friend. We are teaching them this. I would not use a hand-layered porcelain veneer to open bites with today, okay? Even though I know we know some friends in New York that do, and they show all these beautiful cases, and I worry about those cases, okay? All right? I would, if I was going to do, and I'm okay with the composite on the lingual. I like doing stuff like that. I would do a glass ceramic veneer.
You're not understanding what I'm saying.
Okay,
you think I'm disagreeing with you or anything? I'm not disagreeing.
I think we were agreeing. I actually think we were.
No, we're not, because you make a distinction that I don't, and you might be right on the distinction. But the way I teach this is glass ceramics is Empress, lithium silicate, zirconia reinforced lithium silicate. Anything that has a glass face, I cut it except for composite. Yeah.
Porcelain is not a glass ceramic. Porcelain is not a glass ceramic by definition.
So, but that's fine, and that's fine. So, what is porcelain? So you call it glass ceramic, then you can lithium silicate because it has a crystal that grows.
Right.
You call that a glass ceramics, but amorphous porcelain, you call it porcelain. Is that what? Am I understanding correctly?
Okay. So yes. Okay. So the porcelain is thought of. I mean, if you look at it, it's a thing that condenses under heat and contains clay. There's not a great definition. Okay, but typically porcelain and the dental space is a powder liquid system of a glass, okay, that can have some crystals in it. That's built up by a powder liquid on a die, okay, or on a PFM coping or something like that, or zirconia coping. Differentiate that with how our definition of glass ceramic is a block of material that we press or machine, okay? So
Sure, but
we're getting sidetracked here a little bit, okay?
no, we're not. We're not.
Yeah, well, actually, we are.
I'm going to simplify.
Let me just finish. Please let me finish. Please let me finish, okay? And I think we're all going to agree with this. Okay, whether we build up, and I'm fine with the composite, okay, or thing. On the facial, I'm going to put either machined or pressed glass ceramic. That's what I'm putting on the facial. I'm not going to put a pure porcelain on the facial, on something that I'm opening the bite with, and I built up the lingual out of composite, because it's too weak of a material. That's my point.
And so, and I agree with that 100% on this. And what I think bottom lines all of this is that probably 98% of the dentists that you're teaching this to, this argument never even comes up because they are doing a glass ceramics by definition. And Ed's in my world, where 98% of my veneers are feldspathic and layered, it's rare that I do an EMEX period. But if I do have a lingual situation like you're addressing, then I have no problem doing it in composite because I'm going to go with EMAX. So,
right. But I've seen your cases, Richard. Your cases are not heavy bruxers, though. The cases you've showed me.
Correct. That's my point. So,
okay.
So when you're open and vertical on all of that, you're going to change your material. The few EMAXs that I've done have been in heavy bruxer situations.
Yeah.
So that's why I think.
And if you want a little more aesthetics, you use a vita block or impress block, okay? So I think we're basically on the same there. So we've answered that question, okay?
I'm not.
You're not.
I'm not, but no, because I want to be mean, and we can do it off the record, but I think the distinction you're making between these two materials doesn't exist. And I don't want to confuse people, and I'll give you an example.
Porcelain is a different material than a block.
But you explain. Now let me explain what I think. Let me explain my point, which could be wrong. I understand what you're saying, and what you're describing is the difference in the manufacturing process, not the difference of the material.
Right, yes.
Hand-stacked porcelain is weaker than milled porcelain for a block. The studies show that. We know it. You and I know it because we stack porcelain.
Because of the manufacturing technique.
It's not a different part. It's not a different... The block is not a glass ceramic. The block is also a powder that they compact into a square and they put it into an oven, and it's the same one that you're doing. It's just better because it's under pressure and perfectly packed and whatever, or as perfect as it can. So I think the message that you're trying to say, and I don't want to correct you because I could be wrong, is if I'm going to be in this scenario, don't put hand-stacked porcelain in the front. You can use only glass ceramics, but don't use that one because those are weaker by the way they're made. Am I correct or am I wrong?
Correct. Generally, but porcelain is not considered a glass ceramic by anybody, okay? Even though there's glass and there's ceramic in it, the differentiation kind of comes down to the fabrication technique, okay?
So it's kind of like the way we're using the word.
Yes, okay? So, but I think we're going to use the material similarly. We're now arguing about its semantics on,
No. I was confused because I said, well, glass ceramics and porcelain, they're different things. So like, no, they're different manufacturers. What's the next question?
Okay, all right, guys, good job. Let's get through a couple of questions so we don't lose our audience. We're going to answer this question, okay, because it's relevant to what we're talking about. So, do we need retention and resistance form and inlay-onlay preps? Let me move so I can see that, to spare the bond, okay? Wow, okay, so yeah, what you're talking about is tensile stress on the bond. Here, I think we covered that a lot today, but here's the simple answer to that. We would 100% use a glass ceramic, Empress, Emax, Vita block, Suprinity, 100% of the time on our inlays and onlays. If we can control our bond, meaning isolate, do all that fun stuff, we would not at all worry about retentive macromechanical retention, okay? Because the bond has demonstrated to be so strong, okay, that when you, like what Richard said, when you pull it apart, Panavia against the bonding agent, you can't. It's impossible, okay? So as long as you can get good isolation, you've got some decent surface area, not a 1 millimeter square surface area, we would not worry about on our inlays and onlays some retention and resistance form. So guys, why don't you share your concepts there if I missed anything?
No, I agree completely. I mean, our bond strength, but we've known that for years if we're using the right materials. With zirconia, obviously, we have a little different issue.
Yeah, and I think we touched on it.
I will tell you right now, I consider myself pretty high up in the bonding world. There's not a whole lot that scares me if you've seen some of my extreme bonding.
Right.
But I have I'll not lie to anybody out there. I've had zirconias that I put on 15 or 2 where I didn't have much retention form and a wing and a prayer, and I've had a couple come off. And for me to have something debond, I know rare. But I chose that and to try it, to see, and the patient knew. And I said, gold is a better choice here. I can bond gold better than I can bond zirconia.
Well, quick follow-up, Richard, and then Miguel, you touch on it. Specifically, you're prepping a tooth. The question, you're prepping an onlay, okay? Second molar, first molar, whatever. And you've got decent surface technique, and you can isolate. Are you going to cut a retentive groove or a box form?
Absolutely.
Okay, that's the question. Miguel, and the only other thing we would say, and we wouldn't recommend this, but if you're going to use zirconia, cut some in. But that isn't a recommendation.
The only time, and I'm not 100% in agreement on this flat prep, consistently flat preps. You see a lot of aggressive flat preps right now in the biomimetic world, where I think they're even taking maybe more than they need to. Those are the only times that we would put an indication dot somewhere to align the restoration up, to have a seeding index.
And what a concept! Why don't you just follow the occlusal surface and you get that? Okay. All right, Miguel. All right. Yeah, Miguel?
The answer is no. Retention and resistant form are no longer needed in dentistry ever.
Awesome, buddy. Okay. That was simple and to the point. Okay, guys, I think that's enough. I think we're probably well into our hour and a half. And any closing thoughts? God, this is great, guys. I'm having a good time. I love bouncing ideas off of both of you, and I love my rant brother out there. He's making me think a little bit more before this thing starts flapping out there. All right, everybody. So closing thought, either of you two, and we'll sign off.
Thank you, guys. It is an honor and a pleasure. Ed, I'll see you tomorrow in Chicago.
All right, everybody, take care, and you'll see this out pretty soon. And the interview's coming up right after this. Celine Hayden, everybody, signing off the section, guys. Okay. Hey, everybody out there in cyber world. Good morning, good afternoon, good night. Really excited. Our second show here to do our second interview, other than Miguel and I interviewing ourselves, which probably shouldn't count as an interview anyway. So we've got Celine Hayden on board here with us, and I think she's in London. I know she's in England somewhere today, but I didn't ask what particular city. And we got Richard Young, our moderator again, who's going to keep Miguel and I nice, which is a challenge. I get that, Richard. I know how troubling that is for it. What's that? Yeah, cut us off, right? You'll just erase me and turn me off, which that's okay. I know. So anyway, so excited about this particular segment. One of my goals, or our goals, let's say, when we started the concept of an interview, was not just an interview that everybody keeps interviewing over and over and over again, the so-called A-listers or whatever, but great talent out there that we've just, been a great talent. Don't mean to diminish anything, but just maybe people hadn't heard about yet. And so that person tonight is Celine Hayden, and she is fabulous. Richard turned me on to her about a month or so ago and said, hey, we got to get her on the show. So hi, everybody. This is Celine Hayden from England, who might end up here in the United States. We're kind of hoping for that in the future. She does some wonderful stuff in adhesive dentistry and aesthetics. So anyway, we're excited to have her here. So tell us a little bit. First question I always like to ask people is, what got you interested in dentistry in the first place?
It's a very good question, Ed. I started off doing an architecture degree, so quite a way away from dentistry. And I put it this way, I wasn't enjoying it. I got 3 years in. I love the engineering aspect, I love the artistic element, but I wasn't really massively into the creative side, which I know sounds bizarre for dentistry, but actually there's different types of creatives, right? I'm more of a copy the image creative. So when I quit architecture, I was looking at medicine, and as my father, who is not a dentist, he's a chemical engineer, And he said, right, you like art, you like science, and you like working with people. Why don't you be a dentist? And I looked at him and I was like, are you mad? Like, what planet are you on? It makes no sense to me. And then I did some work experience, and it was kind of a gut feeling, really, from that point on.
Wow. Okay. And do you have any other family members and things, brothers, sisters, cousins, anything like that?
Nada.
No,
not one.
Nobody.
No.
Same thing for me too. Nobody in my family. Everybody was in the car business, McLaren. Okay, except for me. But anyway, that's great. So tell us.
Related? Is that a joke or is that?
No, it's not. It is. So if you go up to my dad's great grandfather and come down, you hit Bruce McLaren. Yeah, my dad was in the car business. He had Newport Imports, and yeah. So I just wasn't interested. For whatever, it just wasn't a car guy. It was just not for me. But that's a whole other topic. We can talk about that some other day. Great. So you're obviously born in London somewhere. Where's your practice based today?
I work in Pangbourne, so it's just west of London. It's kind of near Reading, it's 40 minutes west of London. Speaking of cars, there's an Aston Martin garage and a Lamborghini garage just down the road, which I'm a massive car buff, so that absolutely tickles all of my fancies. But no, just not quite in London anymore. I was on Wimpole Street for a while, but I've decided the hustle and bustle of London is a little bit too much. I don't know if I'm starting to sound a bit too middle-aged, but hey.
So I think, did I hear you correctly? You have an Aston Martin?
I wish. Oh my God, I wish.
Yes. Well, I've got my James Bond hat on here, so that's another car.
As the moderator, you might ask her about what she rather rides other than a car.
Oh, this is Jane. I'm more of a two-wheel girl rather than...
Oh, that's right. Richard sent a couple pictures. Wow. I mean, you even do some racing too, right? You do some racing?
Yes, I do. I'm not long for this world.
Well,
she races the McLaren of motorcycles.
Okay. What is that, like a BMW or something? No? I don't know.
Ducati, Ed. A Ducati.
I've heard of the Ducati, okay. Well, God, that's fascinating. How'd you get into that?
Oh, God, I came out of the womb with a love for two things, motorbikes and skiing, kind of as long as I can remember. So the bike thing has always been an obsession, really. I love it. There's just so much precision in it. It's, I mean, you might think I'm crazy here, but it's a bit similar to dentistry. The challenge, the precision, the minute improvements, the kind of the 1% improvement each time you go around. It's addictive. Right. Amazing.
Well, when you get to the United States, if you do, Richard's quite a good skier. I don't know if you guys have ever skied. He makes me jealous, all the fun stuff that he gets to do.
About Marvin. She's a Stokely person too.
Okay. Oh, great. Okay. So, other guys, you got a couple of questions? I got a whole bunch in my head, but I don't want to dominate the.
Let's get to it. Let's do it.
Okay.
So, all right, we go all the way back, right, Celine? We go all the way back.
We actually do, Miguel. One of the very first lives, or kind of, I think anything that I ever did, was on Instagram with you during COVID. And at that point, I was this like shaking little thing. I still am a shaking little thing.
I have another question for you, and the question is because I know a little bit of your story, whatever you told me. You went to architecture school. You did 3 years. You then went on a different direction. I also know, because we talked about in private years ago, that you have this on and off no personality. You have this on and off, at least affair with Instagram, let's say. And I wonder if that's an on and off also affair with life, in which you hit sections of your life and you need a switch. Am I reading that correctly? And if I am, can you explain to me what is the process of wanting change in periods of your life? And if I'm wrong, just correct me.
Well, I think, no, you're right. You're so right in one way. The change thing, maybe not so much, but the switch thing, yes. But I put it in a way of kind of turning a switch on and off. So I'm an all or nothing kind of girl. I think we've already established that with the Ducatis and the skiing. And I find, no one can give 100% to 5 different things, right? So, for example, when I switch off Instagram for a bit, that's because I'm committing a bit more of my time to my family. Or when I'm committing more time to my Instagram is when I drop off the radar with my friends and family if they think I've died. And it's kind of this switch of things being on and off. I always say with my partner, I wouldn't necessarily say there's a priority order of things in life. It's more like there's 5 things lined up in a row and the spotlight just shines on different things at different times. With regard to change, I'm not one of those people who just jumps into a new thing every few years. That's not me at all. I kind of go where the wave takes me, as long as it feels right. But I think you're right. When you said the word switch, I was like, well, to me that kind of makes sense with the light switch thing. But yeah, I mean,
in a way, what you describe is a life in sequence more than a life in parallel when it comes to projects or moments or aspects of your life. What are the positives and negatives of having a life in sequence? Because it interested me, because my life is, I run 20 things at once, and I always do. Yet my wife needs to do it in sequence. So I was always fascinated with people that are different than me. What are the pros and cons of running a life in sequence? Let's go.
I mean, I think running a life in sequence, you get to focus on one thing at a time, whether that be your career or, I mean, I say that this is an ideal world. This is kind of some Marxist utopia I'm talking about, because it never works out that way. You're still trying to juggle all these different things. Yeah. I constantly feel like I'm spinning 8 different plates in the air. And that's just how I think every single person on this call probably feels the same. But I think, yeah, one of the big benefits of running things in sequence is you let it run its course, but you also do get to dedicate that much of your time to it. And you can really get a gut feeling from it. If you're running lots of little things at the same time, your gut gets a bit confused. And I don't mean to sound all kind of thespian and woo-woo, but I do listen to my gut a lot, and I kind of listen to what my intuition is saying. And I think if you're really focusing on just one thing, your intuition will tell you a lot.
You know, what was that? Go ahead. I was just going to say, to add to that, my life sort of bounces back and forth in that mode where I can focus really well for a period of time on a project, but then all of a sudden, I don't know, I get kind of bored quickly. So my wife says I just love chaos. I'm like the Peanuts character where all the crap falls on the ground. So Miguel, I think you're kind of a lot like me too, in the sense that that it's good to have more than one thing going at once too. And I want you to expand on this motorcycle thing. So are you racing professionally, or is this just a very, very strong hobby? I'm fascinated.
It's a very, very strong hobby. It's something, again, I mean, the whole life in sequence thing, as I said, it's an ideal world, but it doesn't happen. Dentistry courses, life, motorbikes. I wish I could fit more time in for the bikes. I want to get my ACU, which is your race license, next year.
Okay.
Just because it's just something I only started on track 3 years ago.
Okay.
And I've taken a real knack to it. I absolutely love it. All the trainers say it's quite exciting what they see. So why not? You know, if dentistry doesn't go well, then I'll take up the motorbike thing.
Well, I'll
budget does it take?
Richard and Miguel, and we'll all come and watch one of your races when you let us know and stuff like that.
What kind of, if you would like to have that hobby, what kind of budget does it take? What are we talking about?
That's got to be expensive. That's got to be very expensive.
I want to jump in. Of course, I need a motorcycle, but beyond that, what are we talking expenses if it's a hobby?
You need the motorbike. All bikes. I mean, motorbikes are kind of like skis, right? So once you take it to a certain level, you need different sets. You need all the kit. So a good set of leathers is $2,000-$3,000. A good helmet is $1,000. A few good helmets, $2,000. You need all the shoes, the airbags. Each time you go racing, so if you're doing circuits, you need a van to take your bike there. You need a toolkit.
Wow.
Yeah, I mean, needlework would be cheaper.
I see Richard checking websites right now to get the bike going.
Yeah.
Me, no, I'm never gonna do. You know, I actually got. It's funny. I got my motorcycle license during COVID, and since I screwed myself up and crushed my hip a few years, but I just decided it's probably not smart to do it, even though it was something I had a idea to do. Well, that sounds fascinating. Well, coming back to dentistry, so because I think we're all here for dentistry, and we can talk more about stuff like that in a minute. So anyway, are you in private? Yeah, I know you're in private practice, but are you teaching a little bit, like at King's College or someplace like that? And how did you end up focusing really on aesthetics and adhesive dentistry?
All good questions. Yes, in private practice, which, I mean, in the UK, I don't know what you all know about the NHS, but it's not very easy to do
a challenge,
in the NHS, put it that way. So it's I learned a lot from it in my limited time on it. But private practice, I don't do any teaching in university. I have been asked in the past, or it's been discussed, and it's a challenging situation in the UK again because the universities are funded by the NHS. So when you're kind of a young budding dentist with not quite the same amount of debt that you have, but also expensive hobbies like motorbikes, it kind of made a bit more sense for me. Anyway, my heart was just saying, I wanted to do dentistry. I wanted to do dentistry. I wanted to do art. I wanted to create. I wanted to use my hands. And that kind of leads on to your last question. So the teaching thing, yes, but only privately. So courses and lecturing and things. But the aesthetic dentistry thing, I think it's my love for art. I've always loved portraiture. So I draw faces.
Oh, really? Yeah.
Wow. And I have done since I was a kid.
Did you take a class, or was that all self-learned or self-taught?
No, it was all self-taught. It was, I mean, I think we're all a little bit on the spectrum as dentists. I mean that in the best way.
Yeah.
And the more I kind of think about it and look into it, the more I think, well, 100%, I definitely fall into that category, because I'll draw photorealism. I love it. Absolutely love it. Pencils, charcoal. And that kind of translates perfectly into dentistry, really, because that's what we're doing, right? We're copying an image. And I know you can relate to that, Ed. I mean, you're absolutely nuts at that stuff. You know, let's build a tooth from scratch, that kind of thing.
Yeah, it's fun. Well, yeah, the same thing. It was just developed an interest and thought it was fun, and you get passionate about something. Interesting, you mentioned photorealistic art. So obviously you studied this a little bit. Did you read a little bit ever about Picasso's early life?
No, I didn't.
Okay, so interestingly, his father, most people don't know this, was actually an art teacher, okay? And as he started very young, I actually saw some drawings that he did when he was like 6, 7 years old, which looked worse than any other 6 or 7-year-old drawing I ever saw. It looked like bad sticks. You couldn't even tell what it was. And then he started to try to be very creative, let's say, as a young boy. But his father forced him, because being a teacher said, no, I don't want you to create anything. I want you to visualize what's in front of you and copy. So his dad wouldn't let him go off on his own until he could do photorealistic art.
Wow.
15 or 16. And so that's a very good lesson, that what you say, you have to learn to be good at anything that's art related, whether it's architecture, dentistry, portraiture, or sculpture. You have to learn first to visualize, and then secondly to copy. Okay, essentially.
Didn't Picasso continue to not be able to draw faces through his entire life?
No. About 17 or 18, if you looked at the images that he did or painted, they were literally photorealistic.
Ah, okay. He probably got tired of that and completely switched.
Yeah, that's what happened. Okay, then his dad let him loose, and he developed this style that we all seen, everybody's seen by now. Oh, that's awesome. So you're teaching courses, I guess. So I see that you're going to be in the United States. It's fun talking about art, and I think you're doing a course on isolation, I believe in April, as I saw. So tell us a little bit about that, but also tell us, because literally, I'm not exaggerating, she does some of the nicest freehand bonding I've seen anywhere in the world, as good as anybody that you've ever seen out there. So are you doing any course soon in the United States people might be interested in?
Well, that means a heck of a lot coming from you, Ed. I can retire now. But yeah, the course in the States, I've been running courses in the UK for a while, and for some reason, and you know what, Miguel, actually, I think it's off the back of that live I did with you during COVID, I've got quite a big American following. And so when all these courses are going, so thank you for that. So all these courses in the UK, people are asking the States, when are you coming to the States, when are you coming to the States, when are you coming to the States? And I just thought, well, why not come to the States? So I happened to be in America last December. I was with Amanda C. and Adamo in Charleston, and I was just mentioning that I was wanted to run a course in the States, and that's when Perry Levitt's Center came up. And it all kind of made perfect sense, because the course is tried and tested, works really well. And a lot of American dentists I've spoken to, and this might be a contentious issue, this might be a contentious opinion, it might not be, and there's all sorts of different types of dentistry, but a lot have said there's a lot of need for good rubber dam courses out there. It's something that kind of needs to be picked up on a bit. So I thought, okay, right, well, I'll just find my niche, or my niche, as you guys say.
Right. And I know you do a fabulous course there, but I'd strongly recommend you put a couple of bonding courses on the books too, because I think you're going to find maybe a little more interest there, because people just don't know how to do that. But also to give a plug to Miguel, he does a fabulous isolation rubber dam course too. So,
Salim, my question for you is, how we met originally was when she just kind of thought it was a tongue-in-cheek. On Instagram, she posted the use of an explorer to invert a rubber dam. And in 1983, Dr. Greaves out of Australia was our rubber dam guru at Loma Linda. That's how he taught us to work, was with an explorer in 83. And so my question to you is, in comparison to the United States schools, for instance, Loma Linda, rubber dam is a given. You have to use rubber dam all the way through your education. Most students leave and never want to touch it again. A lot of us have done that since that day and had never really left rubber dam. How is it in England? And then number two, you're in a group of photographers here, as you know. Ed and I, Miguel, go back a long ways. Ed and I, over 40 years in dental photography. Who was your mentors and who influenced you?
A great question.
In the rubber dam and photography. Kind of curious, because that was the other thing I noticed about your site immediately was your lighting was really clean. It was really pure. It wasn't overly diffused. It was really high quality, and that's what caught my eye on your Instagram originally.
Oh well, again, that means a lot. I'm going to be saying that a lot. Good questions. I think rubber dam, the uptake of it around the world, is great amongst those who are passionate, and not so great amongst those who are not passionate about it. It's something, because it's not a treatment. You don't need to do it. It's not something you have to follow through with. Whereas, you start a veneer preparation, it starts going wrong, well, you've got to finish it. Whereas rubber dam, it's one of the first things people give up on. It's the same in the UK, where when I trained not too long ago, we did everything under rubber dam, but it wasn't particularly well taught. It was very much like, here's a dam, here's a clamp, make it work. So, well, honestly, it was put a hole in it, try any clamp that works, and it was just kind of, there was no method to the madness, and it was really a bit of a lottery. And so I think a lot of people did give up on it afterwards. I just happened to work in a very a wonderful but quite outdated practice as my first job, and they didn't have any rubber dam equipment. So the guy said, "Hey, do you want to just buy what you want then?" So I started looking at the ordering book, being like, right, okay, let's think about this. Okay, right, I want a square clamp for a square tooth. I want an asymmetric clamp for an asymmetric tooth. So started kind of putting it together there. Right. But a huge part of my rubber dam and photography story was a dentist called Thomas Taha, who works here in the UK.
Sounds
his Instagram account is drth.co.uk. He works in Abingdon. He is just on another level. He wants to be an artist. He was born to be an artist. He admits that he'd like to be an artist, but he's settled with dentistry, and he does that kind of dentistry. So a lot of my rubber dam inspiration came from him. This was the first course I did when I qualified in 2017, and I just was inspired from that day on. He helped me a lot with photography, but then a huge help for my photography was a guy called Minesh Patel, who's got an amazing. Sorry,
he did a couple books about 10, 12 years ago, right? I think or at least one.
Did Minesh. No books. He's quite young. He's been qualified for about 10 years.
He's really good.
Maybe longer than that. 15 years.
He's
but he's phenomenal. His photography, the way he thinks, he is a lateral thinker. He's a problem solver. He's an innovator. So he, the way he looks at it, it's not every single practice has the space to have a giant softboxes. Softboxes on the ceiling.
Yeah.
So he has created a photography course where it's all done on the camera. And I've changed the diffusers I use. I changed some of the systems I use, actually, thanks to Richard Young, who's my next biggest inspiration for photography. So it's kind of been on a journey in that sense.
Yeah, and just to add, Richard's been great. When I ran a program at UCLA full-time, as you know, up till a few years ago, and Richard was phenomenal. He came out every year, volunteered, and taught my students, and I just was always amazed at the practicality of how he did everything, plus the quality of everything. So, well, great. So the other piece of that pie was what got you fascinated with adhesive dentistry, because as we all know, everything in dentistry, but especially that, is just getting dumbed down to mix something up and you're done. And they expect it to stick to the teeth, stick to the restoration, and stick to everything, and we all know that it doesn't. And so that's its own. It ought to be its own specialty to a certain extent, but you do it at a top level. And just like you were saying, what happens in England, the same thing's happening in the United States. It's literally scary what's going on in the United States in dental education for lots of reasons. They just don't have the people to teach. Number two, the economics of it is so poor. When I left UCLA, just to give you an idea, from when I started and left, they only have a requirement after 4 years to do 5 crowns. They graduate doing 5 crowns. Think about that. Richard does, some of us do that in an hour some days, right? Okay, imagine your skill set, your abilities, if you've done 5 crowns your whole dental school career, and that's not too dissimilar what's happening around the United States. So my question was, what got you motivated, or who were your mentors in adhesive dentistry?
It's the same here in the UK. When I qualified dental school, I was fortunate. I'd done over 200 composites, and I think I did 4 amalgams, which is unheard of. Normally in this country, it's the other way around. But King's is a real pioneer. Yeah, in this country, exactly. If you're lucky. Yeah. So I think it started at King's really. It's got its shortcomings like every university does, but it's got some amazing qualities there. And one of them was to be a real spearhead driver for adhesive dentistry.
Good.
For those qualifying today. Was it the adhesive dentistry I know now? No, it was a foundation level, as all university is.
Yeah.
But it just made a lot of sense to me. It was, if you're looking at getting a hip replaced, you're getting ceramic hips, you're getting the newer age materials. You don't see people using the older age materials that they used 20 years ago. Right. Whereas for some reason in dentistry, we think that's okay. Right. We think it's okay just to, I'm good at placing my dentine pins. I've been placing dentine pins for 40 years, so I'll keep doing it.
Yeah.
It's an odd system. So to me, it just made sense, the adhesive dentistry journey. I was very, very lucky, I think, to qualify in the time of Instagram, where you suddenly have connections and contacts with dentists around the world, leaders around the world in their field. You can see what they're doing. You can be inspired by what they're doing. You can see what's possible.
Yeah.
And I think that's what kind of spearheaded my journey even more. Whereas if I'd qualified 20, 30 years ago, like when you guys did, when there was no Instagram, no social media, you couldn't see what was out there, and you really just learned from who you were around or from the conferences you went to.
That was our topic of our first show, that the conferences, even still today, but you can't get on the stage unless you've unless you're related to somebody. It seems like today, right? Okay, I could go down.
That's the Ed I know. That's the guy I know.
I could go down a rabbit hole there.
The Keystone Golden.
Yeah.
No, we don't want it. We're gonna piece.
No. Listen, well, we already did that. We already did that rave and rant, but
bitchy.
But so true. And then that's the wonderful thing about Instagram. Obviously, the other side of it is as self-appointed experts that have just get out there.
Mm-hmm.
Yeah. So that's what we'll make sure we market our course here, and then I think maybe between the three of us, we see if we can help organize a bonding course. I don't know if Miguel told you, but he's building a brand new facility. I'd love to come out and take it. So
it's going to be amazing.
That would be awesome. And then I got some friends I can introduce you to in the United States. You probably know them anyway. They got training facilities. One of my good friends, Tony Sedler, who owns Burbank Dental Lab, he'll let anybody use his training center for free. Great. We can certainly help in that area. Miguel, you got another little follow-up question, and we'll kind of...
I do.
People don't know, but 3 years ago, Selena and I were talking about doing a course together. We had it all lined up. And then she went in another direction, business-wise, project-wise. Without naming names, Celine, without trying to throw any shade to anybody. Tell me about that experience of working with that group that you worked for a while and then you left. What did you see? What did you experience?
I learned a lot. I joined it. I'll tell you why I joined it. So I was being asked to lecture somewhere, and I was speaking to a guy who's a member, and he said, "What are you charging?" And I said, "I'm not." And he said, "Why aren't you charging anything?" I was like, "Well, I don't know what to charge." And he was like, "Oh God, say no more. Say no more. You need to meet this guy because you need to learn." Little caterpillar. So I joined it, and I learned a lot about business in that way. So stuff that as you all know, as dentists who lecture and educate, you kind of have to learn this stuff on the job. There's no instruction manual. There's no one teaching you. There's no one saying, especially if you're from the UK or lecturing the US, rates are very different. So to learn these things. Right. So I learned a lot in that way. I met some amazing people. I met some lovely people. Some people who I already knew very well before. But in all honesty, I left because everything that I'm achieving now with my career and everything I had achieved to that point were all my own. I hadn't relied on that group for anything. It hadn't got me into any organizations or anything like that. And there was a part of me that thought, you know what, I'm doing okay by myself. So I'm going to keep going by myself with friends around me, but without being kind of committed to a group like that was my thinking.
A true artist.
Who's organizing your courses here in the US? It's just you, or somebody's bringing you in? How are you doing it?
It's just me. So I spoke to a guy called Paul Renan, who works with a guy called Carrie Levitt. Carrie's got his training institute down in Vegas, and so Carrie and I had met before at a conference last year, so it kind of all worked out really. And I mean, as you well know, the marketing piece that is social media, I guess. So I kind of went off the back of, right, well, there's interest for it. People want me to do it. So it's just that. But it's the same in the UK. It's just me. I wish it wasn't. I wish I had a team and all of that. But it's just me for now.
No, Ed and I know what that means.
I got to agree with you. I've gone through that whole cycle over 40 years, being with somebody that marketed me, giving somebody half off the top. And it was just as much work and just less profitable if I just did it myself and I had a little bit more control. It's a lot of extra work though.
Nothing that was promised is there. So you sign a contract, you say, I need this room, this AV. You get there and nothing's there.
Yeah. Well, we've all been there. Well, great. Let's wrap up now. So, Celine, love to any final thoughts, anything that you want to add. Like I said, we're loving it if you show up in the United States, but if not, we got a trip to England. We got a plan, Richard. We got to go.
Oh, absolutely. How much fun would that be? I'll take you all on a tour of London on the back of a motorbike. Ed, you can go in the sidecar.
Let's do it. Let's do it. Okay. Well, thanks Celine and Ed. Go. Sorry, Richard. Some final thoughts, buddy.
Where was your last ski trip?
When was my last? Over Christmas. I'm spoiled. I ski every Christmas. Always in Maribel. Always in the French Alps. So that's a home from home for me.
Oh, great. Miguel, any thoughts? Any last thoughts, buddy?
Celine, it's just nice to see you. Nice to know that you might be heading to the US to continue the courses. The Dental Academy doors are still open, so we can also...
Thank you, Miguel.
Celine, so you're having a course in Las Vegas, is that correct?
Yes, I am.
When is this course? What is it about? Is it 1 day, 2 day, hands-on?
It's 2 days. 2 days. 2 days rubber dam, which a lot of people think 2 days in rubber dam, are you mad? But for me, it feels like it's not enough. So it's 2 days on, I believe, the 11th and 12th, but my head is now saying 12th and 13th, but it's on the Friday, Saturday of April, essentially. I need to remember those dates. 2 days.
The weekend before the ACP. The ACD.
Weekend after AACD.
Weekend after ACD. There you go.
Okay.
Yeah. So it's didactic and hands-on. So day one is kind of straightforward rubber dam. It's all on phantom heads, and that's a big change I've made with all my hands-on courses. So I've bought all my own phantom heads, and I think for rubber dam especially, it is essential to train on a phantom head with soft tissues, because otherwise you're just putting a dam on a typodont and it turns into a trampoline. And we all know that's not the same as a mouth. Yep. So day one is kind of the more straightforward scenarios. And day two is the more advanced kind of deep margin elevation, last standing molar, injection molding, veneer fits. And a combination of hands-on and didactic for 20 delegates, 2 days of fun, enthusiasm.
Where can people sign up?
Online. So I have a website, it's isolate-usa.com.
Isolate.
Yeah.
We'll put some copies, some text on there when we have it.
I use for plexiglass or rubber dam device every day.
Yeah. We know Richard. He wants to put a rubber dam on my face, so. All right, everybody. Well, thanks for tuning in, and Celine, a special thank you for being here on this. And so we're looking forward to your course and everything. Thanks, everybody. So
Thanks, Celine.
See you all.
Thank you. Guys, thank you for having me. It's been a pleasure.